and in Tamale, but you hear about that soon. So this is why we are here, because we are here to have a media tour in the facility to understand what goes into claims processing. Usually when we tell people that it takes not less than 60 days to vet a claim before payment is made, people think that it is unreasonable, people think it is too much a period. So I think today offers us an opportunity to dilate on that aspect of our operations. So Dr. Selby, we'll hand over to you.
Thank you very much for coming. This is when the health insurance first started, as you're all aware, we had all these district schemes and the claims were being processed at the district schemes. And this was incredibly inefficient because apart from processing the claims, you need clinical judgment, and we couldn't put clinicians in 155 district offices. So it was felt best to consolidate at the CPCs. CPC Accra does Volta, Eastern Region, Greater Accra. CPC Kumasi does Ashanti Bronx. CPC Cape Coast does Central Western. And CPC Tamale does the 3 northern regions. Now, in a year, we have 36 million claims. If you can, Julius, if you can pass an envelope. The claims are packaged in envelopes of 200 each. And so you can imagine, today is a good day. Usually the corridors are lined with boxes. Each envelope has to be opened and checked for its contents before the provider goes away. So if, for instance, Kolebu comes usually with a pickup, so many of these boxes that we have to check with them before they go, before we process, write reports and send to them. So we're going to walk you through the process for you to actually see what happens. NHIA spends 80% of its income. 2014, that was 1 billion Ghana cedis on paying claims to the hospitals. And if we don't check it properly, we'll be overrun. Even now, the estimated wastage, leakage, abuse, whatever, is close to 20%. That is money that can be used to build roads and hospitals and pay the doctors so they don't go on strike. So the work we do here is incredibly important to sustain the scheme. So we have, currently CPC Accra is close to 1 million claims a month, 1 million individual sheets of paper that have to be counted and checked. So you can see only 20 staff and they do 1 million claims a month. But you have a summary sheet that outlines each patient you see and the total amount. And we need to check that the summary you've given us matches the actual individual claims, one by one, counted, the total amount, the right name and whatever. If there are any discrepancies, we calculate it and put it in the summary sheet. So this is before we've even vetted. And even if it's one person, we calculate and add it up. So this one was just 3 CDs. This one is 140 CDs. That's the difference between what he told us in his letter he had brought and what he actually brought, individual claims. And if you think that every month 1 million claims goes through our hands, and we allow 100 CDs here, 200 here, 1,000 here, by the end of the year it's 1 million CDs plus. So this is the kind of thing this department does.
Looking at how tedious the work is, paper with humans and co, don't you think technology could have played a very vital role, whereby you could meet some IT professionals for them to develop some software?
Yeah, don't go far. We already have all that software. We are ready. It's our hospitals who are not quite ready. So we do have electronic claims. We'll show you as we go around. Currently about 100 out of the 4,000 providers submit electronically. So it is something we are working on, but we cannot force them to send their claims electronically. So it's something we're working towards. About 12% of the claims come electronically.
So what happens, or what do you do to the institution that whose this thing doesn't tally, whose papers don't tally?
Oh, we just won't pay you. So we write a report and we tell you what the difference was and that we're not going to pay that amount.
So can they rectify and claim it later?
No, because at this level, what it is sometimes they'll tell you they brought 1,500 claims. When you count, it's only 1,450 or something. So there and then, the person is there, and you tell them this is the difference. If it's a lot, they may choose to take it back and go and sort it all out and resubmit properly. Otherwise, a lot of them just let it go. But we sign an agreement between the two parties that even though you said you brought 1,500, you only brought 1,450. Once that is signed, then we begin to process and vet the claims properly.
Don't you think you are understaffed here? Looking at the volume of work.
Payroll is my answer to you on that. We cannot employ, ad infinitum. We've reached a sort of steady state, and now we need to encourage electronic claims because that one, the system does the fulfillment. We don't need any human intervention, but we cannot keep employing staff forever. The government can't afford it. We're a government institution. So you can see the boxes and boxes of claims. So all these have been processed already. We have to keep them for 7 years legally. So we're waiting for them to be taken to our archives. So once the fulfillment has been done and we all agree on the number of claims the hospital submitted and the monetary value, then it is distributed to a vetting team to actually do the processing. Okay, this is somebody who went to the hospital with a cut. They've given an injection here, human immune tetanus globulin injection. Now this is it costs about 25 cedis for a vial. And you usually give it in a situation where the person has not been immunized, the person has a very dirty cut, and there's a danger of getting tetanus imminently, especially if they've been at home before they accessed care. So you don't give it to everybody with a cut. Unfortunately, since health insurance came and put this medicine on, everybody with a cut, just even a bruise, then they will bill us for this. The second thing is most of the hospitals in Ghana don't even have it. What they have is the tetanus toxoid, which is a program drug given free by the ministry to all hospitals to boost your immunity against tetanus. So most people with cuts, or the pregnant women, that's what they get. And it just boosts your immunity. This is only given when you feel the patient, there's been a delay and you are afraid the person is going to get tetanus. So they've had to go through, this is a whole load of them. I mean, we will write to the particular provider. Oh, I think they've taken the name off. So we will write to this particular provider and tell him that all the tetanus things that he gave, we are not going to pay for it because we know he didn't have it in stock. When it happens like that, when we see so many, we actually go there and check your fridge and pharmacy. And we know this person doesn't have it. But, 24 cedis, 60 pesos for one. And look at all of this. This is just free money. Free taxpayers' money, you and me, our money. So we add it all up, and then whatever they submitted 100,000, you add this up, it is 5,000 cedis. We'll minus it and pay you minus the 5,000. But there are lots of other issues. Sometimes the person, they write malaria, they give antibiotics. Unless you write some other diagnosis, they will not pay for the antibiotics because malaria is not treated with antibiotics. Sometimes I've talked about male patient having a female disease. You cannot have pelvic inflammatory disease. You cannot have, as they call it, white. If you are There are some female things. Don't write it there because we won't pay. But this is what takes time, because they have to check every single one and write the amount to be taken off on the front of the claim. From there, to go to data entry, they will calculate all the deductions, and then we add it up and take it off what we are actually going to pay you. Once they've done all this, the summary sheet, we have a soft copy. We actually merge it and make sure there are no duplications, because that's another thing. You find that this claim is number 9. When you get to number 502, it's the same patient, same date, same diseases, but added again as if it's another case. So we have to also take our time and weed out all the duplications. Tricks they play on us. When you go for a delivery, they will put in a claim for antenatal visit as well, as if you had a full antenatal visit, then you had a delivery. They even add a postnatal visit for the mother and the baby before they leave hospital. So instead of just billing us for a delivery, you've got 4 or 5 claims all mixed together, same date. And so again, the staff have to take their time, look at the Excel spreadsheet and weed all that out. You find outpatient and admissions, all same patient, Ekuamansa. She went to outpatient on the 14th of July. But there's an inpatient claim from the 12th to the 16th. So if she was in hospital 12th to the 16th, how did she attend outpatient somewhere in the middle? So all these things take time. You really have to go through and weed them out, add it all up, and then take it out of the amount they are claiming for.
When you detect all this forgery business going on in the service providers and the like, what should I say punishments are in store for these people?
First of all, we have to be sure when we say forgery. How do you know it is? We all know how busy the doctors and the nurses are. So invariably, they leave these things to service personnel. And this is where a lot of the mistakes come from. Not all of it is deliberate, because these things are so obvious. Those who are doing deliberate, trust me, they are proper organized fraud. These tend to be mistakes and errors. And so at the moment, we just take our money back. But this is what leads to the delays. If you have clean claims, it will be so quick to process and send it for payment. When it comes to real fraud, that one, it's we don't let it go.
So
Trust
what
me.
do you do?
We have people who are in court. Some people have gone to prison and all that. We may even sell some of them their assets to get our money back. So we don't take it lightly. But it's a very new thing. So we also have to be, a bit softly when it looks like errors. When it's deliberate, then we take a different stance.
So the 10% that you are talking about, is it because they want to defraud you, or it's an oversight?
I think a lot of it is oversight. But now we have clever providers who are really doing organized fraud. But let's be honest, health insurance fraud is big business in this world. In the US, I hear the mafia prefer it to the drug stuff because it is easy, it is clean, you can get your money and walk away. Chances of being caught are very small. The US has $2 billion Medicare fraud every year. $2 billion. That's like 4 times what we pay in claims. And that is just their fraud. So it really is big business. We are very wary of doing it to providers in rural areas. We'd rather monitor you, caution you. If you're a maternity home, we'll call the midwifery council to have a second look at you. We can report you to the medical and dental council. We have done, especially if you're in a rural area, so that they pick you up and train you. If it's out and out fraud, even then, there are a few we've had to really scare them, take away huge sums of money, but where they are located will deprive the community. So we just keep. If it's in the city, hey, I mean, if there are 100 clinics here and you want to misbehave, that's your problem. So the vetting officers just need to check treatment, diagnosis, and those kind of things. However, the computer, you can write business rules to check some things. So for us, for instance, we can check that no man will have any pregnancy-related diagnosis. No woman can have any prostate and those kind of things. We have special tariffs for newborns. Once you are over 1 month old, in fact, we've set it at 1 year. So it will check, the system will check the date of birth. If you're more than 1 year old and that kind of diagnosis has been brought in, it will flag it up for a clinician to decide whether we pay or not. So if you are, there are different tariffs for children, for instance. If you're an adult and you use a children's tariff as we use, the claim will be rejected. So the computer does some of the work. But as we get more and more sophisticated, we'll put more and more business rules in so that the human intervention gets less and less. At the moment, there are still a lot of errors in the claims that are coming. So we are still having to do quite a bit more human intervention than we would like. But at least data entry, fulfillment, and all those areas are done by the computer. It's just the actual vetting that we are still having to do intervention.
Have you had a situation where you've been able to clear a service provider, there was no mistake whatsoever?
Oh yes, there are. Sorry, especially the smaller facilities, because they only have maybe 50. They only saw 50 patients for the whole month. You can do it without mistakes, that's for sure. But once you get to the bigger facilities and it's thousands, we're all human beings. The mistakes will be there. But the smaller facilities now, we've got to a point where a lot of them do not. There are no vetting deductions. For the e-claims, when you